Dr. Affizal Samsudin. So let me introduce Dr. Affizal. So Dr. Affizal actually obtained her undergraduate medication from the Trinity College in Ireland. So he's a senior medical lecturer in the Department of Medicine, UNIMAS. He graduated from the Trinity College of Dublin. Then subsequently completed her MRCP Ireland and have some extensive working experience in Ireland. So he came back to Malaysia, and he has more than 10 years of working experience in both Ireland and Malaysia. And his special interest is in geriatric care. He's also an excellent teacher and medical course coordinator for clinical year for medical undergraduate course. So his area of research interest include geriatric patients with advanced chronic medical condition. Let's welcome Dr. Affizal.
Okay, thanks, Johan. Just share my screen here. Okay, look, Assalamualaikum and good morning to everyone. Thank you so much for joining our internal medicine course. So I've been given the privilege to give a talk on approach to dementia. Though the 30 minutes is rather quite short to cover the whole thing on dementia, but we'll do our best. So during this talk, just the topic outline about the talk. I'll give a brief introduction on aging and then our aging populations, the term on the major neurocognitive disorder or dementia and the screening tool. We're going to touch a bit about cognitive aspect, the BPSD, and then the general overview of dementia, though we do not have time, so we'll try to just mention a couple common ones. We're going to have a bit of case discussion. And then we're going to talk about pharmacological and non-pharmacological therapy, carers burden, NPI scoring system, and palliative care in dementia. Now, some of the talks I'm giving today, we will be using the latest Malaysian CPG guideline, the 3rd editions, though there's not much change from the 3rd and the 2nd edition. This 3rd edition just came out late last year, earlier this year. So moving on. So when we talk about aging, by definition, aging is a process that converts healthy adults into frail ones, in which there's a diminished reserve in most of the physiological function of the systems. But subsequently, when you start to have a diminished reserve, there's an exponential increase in the vulnerability to most diseases and death. So when we start looking at the lifespan of human being itself, the longest surviving was actually Jean-Louis Clement at the age of 122. And we have, for the man, we have Mr. Jerome Kimura. This figure here, just to illustrate the oldest known species. If you start looking further down here, the shortest survival of species, we start looking at the house mouse only for 6 years, deers for about 10 years, turkey about 15 years, dogs 29.5. Whereas on the other end spectrum, we're looking at tortoise, the lifespan is all the way up to 152 years, and human being second, followed by whales. So probably the best thing we should do is probably just slow it down a bit. Maybe that's one way that we can try to have a longer life of longevity. But putting that aside, now we start looking at the lifespan of human being as well. Back in the old days, in the early 19th century, people did not have the luxury of dying from heart attacks. Back in the old days, they probably died because of infectious disease, parasites, And it's all related to the sanitary system and hygiene back then. Now, but if you start looking at the survival curve, this graph shows the median age starts to increase in the 1980s, where the life longevity and life has been prolonged because there's a marked improvement in terms of the medical healthcare and so on. But of course, with the rise of this whole thing, then we can see a rise in terms of the non-communicable disease. And one of the culprits is the smoking itself. If you look at the hazard of smoking and benefit cessation here, in the 1950s and the 1960s, you can see there's a huge peak there in terms of the smoking habits. And of course, there's an increase in the smoking pattern. We'll see an increase in terms of the cases of lung cancer as well. But don't forget, the one who promotes this are the doctors themselves. You know, this is an ad in the 1950s and the 1960s of Camel brand. Right? Say more doctors smoke Camels than any other cigarettes. T for the taste, T for the throat. That's your proving ground for any cigarettes. Yes, the doctors and 20,679 physicians themselves say that Lucky Strike is less irritating and it's toasted. So the media and the doctor themselves are partly to be blamed in the 1950s and 1960s for the spike. But when we talk about the aging populations, yes, we are going through a silver tsunami, where there's a marked increase in terms of the aging population. If you see here, Italy itself, 24% doubled within 15 years, and the rest of the developing world, they tripled within that 15 years as well. Now, when we start looking at Malaysia itself, yes, we're seeing the same trend again. In the 1960s, there were probably about 4% of the aging population that tripled to 12 to 14% by 2030. So when we see an aging population, of course, we would expect an increase in terms of the NCD as well. And one of our concern now is there's increase in terms of the dementia being seen. Now, but dementia is not a new disease. It's been there even in the first kingdom of the Egyptian in 3500 BCs. So this is a letter of instruction to the pharaoh back then by the vizier Tahotep. But if you read it carefully, it says, O Prince, my lord, the old age has descended. Feebleness have come, childishness is renewed. So he has properly described some of the characteristics of dementia here. Now, the eyes are small, the ears are deaf, probably with glaucoma and cataract back then. Energy diminished, heart has no rest, the mouth is silent. Again, there's a part of the cognitive aspect, and he speaks of no words, and he remembered not of yesterday. So it's very well described about the features and characteristics of dementia, though they did not call it dementia back then, and probably a bit of osteoporosis here. The bones are painful throughout the body. But in terms of the dementia itself, how severe the impact that we're looking at dementia, one case being diagnosed every 3 seconds worldwide. Now, the cost itself is probably what Elon Musk will not be able to earn. We're talking about US of 2 trillion by 2030. The number of cases worldwide, 130 million. And we see quite a big spark in the cases of dementia, mainly in the low and middle income countries. By 2050, 68% of the world population having dementia will be coming from the low and middle income countries. And Malaysia itself, we can't run away from it. By 2050, the projection is going to go up to 600,000. So it is an important thing that everyone, healthcare workers, and almost everyone need to know about it. It is the main cause of dependency in older adults. One of the issues is not everyone will receive a formal diagnosis on it, and there's very lack of research funding in terms of the dementia itself. If you compare to the cancer research, it's only about 10% of the cost. And of course, the fear of getting dementia is worse than the fear of getting a diagnosis of cancer, heart disease, diabetes, and stroke. I'd like to draw your attention on the new definition of the dementia, aka the major neurocognitive disorders. Back a while ago, we were dependent on the DSM-4 criteria, in which for you to actually define somebody with dementia, the patient need to have a memory impairment. Now, that's the first cardinal thing for you to establish a diagnosis of dementia based on DSM-4. But then again, you need to have at least one of the other cognitive aspect being affected, which is aphasia, apraxia, and so on. But this definition, they had to revise it because based on DSM-4, not all type of dementia may have memory impairment as the first thing that they present. So now we stick to DSM-5 definition, which is rather more practical, and we can pick up more, we can define dementia much better. So the key thing is they need to have at least one of this cognitive aspect being affected, either learning and memory. Patient may have difficulty in terms of the language, performing complex tasks and executive function, a problem with the perceptual and motor, and then the social cognition. But the important bit here now is this level of deterioration in terms of the cognitive must be significant enough that it affects their daily activities. Now, you need to exclude delirium. Delirium is a big topic by itself, but a simpler way to put it, delirium is an acute confusional state from a particular cause. And you need to rule out other mental disorders such as the psychiatric or the schizophrenia or major depressive disorder. We mentioned about the daily activities. Yes, we've seen this Bartel score. We need to bring this back routinely in our clinical settings, especially when we're dealing with geriatric populations, because it will give us a rough idea what is the functional ability and capability of the patients. Now, when we talk about the functional activities of daily activities, it could be in terms of everything and anything, as simple as eating and drinking, shopping, cooking, and the mobility. So when I talk about dementia, I like to look at it into two aspects. Number one is from the cognitive aspect, which is quite a simple thing, but the other difficulty aspect, which is the non-cognitive aspect, which is the BPSD, in which we will talk later on. So keeping in mind about how our brain works. Now, these are all the cognitive aspects that we're looking at. Now, for example, the frontal part of the brain, just as recall, to refresh about our neuroanatomy, is important for planning, organization, even talking, working memory. When we talk about the parietal, reading, writing, spatial orientations, we talk about occipital, it's quite obvious in terms of visual processing. The limbic system is important for emotions and memory, and the hippocampal region, which is very important in terms of laying down the memories. And finally, the temporal lobe, which is important for the auditory and the language comprehension. Now, when we talk about cognitive aspect, these are the parts that we need to pay attention to when we address a patient that we suspect of dementia. Now, of course, then, what tools do we have? We need to start screening those who we suspect of having a major neurocognitive disorders. But a routine screening is not really recommended because it will be almost, number one, it will be almost impossible to routinely screen for dementia. So, but we need to actively look for them as well, because even studies have shown that even physicians themselves only diagnose only about 18.7% of all patients with dementia. And then by the time they reach to the clinical settings, being referred to us, they are probably at the moderate or severe stage already. Okay, so we need to keep in mind about these 10 warning signs, especially in the clinical settings. Number one, patient may have a problem with the memory loss. When we talk about memory, we're talking about the recent memory or remote memory. In most cases, dementia is always the recent memory which is being affected first. They may have problems in terms of performing familiar tasks. For example, they could be an accountant, a banker, and then they may have problems with simple mathematical calculations. They may have problems in terms of language, decreased judgment. And one of the common things that the patient will always complain is misplacing items. Not once in a while, but quite frequent, to the effect that it probably affecting their daily activities. They may be withdrawn from the social activities and work, probably having problem with the visual and spatial, and then they might be change in their behavior and their personality, and probably might have problems in terms of disorientation in time and place. So these 10 warning signs, please keep it in mind. So whenever we're reviewing a patient, we need to keep in mind that there's possibility of dementia there as well. So screening can be something as simple as clock drawing test. Yes, we do not have time. At least do a simple clock drawing test. We can do a bit of abbreviated AMT score. MOCA, quite complex. Complete MOCA will probably take you about 20 minutes, but MOCA is quite sensitive in picking up mild cognitive impairment. So, but we're all familiar with MMSE. Now, when we talk about MMSE, which was introduced by Holstein in 1975, so there are about 6 domains here that we need to look into, and each of these domain would correspond to a certain part of the brain. For example, tests that we keep on doing. Can you spell the word backwards and the serial 7S? Basically, it's a test for the frontal and so on. So do keep in mind, whenever you're assessing a patient with MMSE, which part of the brain that we are trying to assess. Okay. There are other screening tools. So this is just a summary of all the screening tools. So it's good to familiarize yourself with at least one of the common one. For example, the MMSE. MOCA, like I mentioned earlier on, is very good to pick up the mild cognitive impairment, which is a warning sign before dementia. So who gets dementia? Now, when we talk about the risk, yes, back to basic again, there's the modifiable risk and there's non-modifiable risk. The non-modifiable risk, we're talking about, for example, patients with strong family history. They may have Down syndrome, they may have mutation in the amyloid precursor protein. And the non-modifiable, we're talking about lifestyle, sedentary lifestyle, high alcohol consumption, smoking. And but of course, female gender itself is a increased risk of for a patient having dementia, not because of the gender also, but maybe because of the protective role of the estrogen to prevent the amyloid toxicity. And number one, number two, we know that females, the lifespan is much longer than men. Thor, yes, Thor, Chris Hemsworth, he's worried about Alzheimer now as well. This just came out just recently, about a couple of weeks ago, where he started to become worried about his Alzheimer risk. No, he did not get the risk from the movie Endgame, from boozing or from the sedentary lifestyle, developing the obesity here. No, he did not get it from there, but it's more so of the apolipoprotein epsilon 4 gene. Now, all of us have a carrier for apolipoprotein E, but then whether we carry the E4, E2, E3 is a question. But for someone who has E4, the risk of developing Alzheimer increase. If you carry one of them, the increase will risk by 2 to 3. If you have 2 of them, unfortunately, your risk will go up by 8 folds. Okay, so unfortunately for him, the son of Odin, he has both of the E4. Moving on to the modifiable risk factors. This is something that we can do. We can try to advise our patient in clinical settings. So on all these things that we can try to modify. Okay, so we need to get them physically active. They smoke, you got to stop smoking. You drink, you got to stop the drinking. Somehow air pollution is associated with risk of dementia as well. Infrequent social contact. Get the diabetes, hypertension, all the metabolic syndrome disease under control. Depression and hearing impairment. And then similarly, what they found, people with less education, they have increased risk of developing dementia in later life. But of course, when we talk about education, we talk about the formal education and the non-formal education. So basically get them to start working and, get them active again. This figure is from Lancet. I really like this figure. Basically, if you start looking from the top here, this is the risk factors we're talking about. If you're a carrier for apolipoprotein E4 like Thor, there's nothing much we can do about it, but at least get the education up, okay, in the early life. So you need to get all these educations, get them very active in early age and all the way until the end, okay? But then problem comes, such as hearing loss, hypertension, obesity. This is where we can try to help these patients. And later in life, these are some of the things that we need to address as well. Smoking, social isolation, and diabetes. So there's room for us to go in to reduce the risk of our patients developing a major neurocognitive disorder. I'd like to show these slides here because if you see, all of them have one common thing among all 3 of them. Yes, all of them are actors. Some of us are very familiar with Charles Bronson, the guy from the Dirty Dozens, and then Robbie Williams and Sir Bill Connolly. What they all have in common is they all suffer from dementia. Okay, like Charles Bronson suffers from Alzheimer's disease. Robbie Williams, famous for his bizarre kind of acting with personality borderline kind of disorder, kind of trait. He has a Lewy body dementia. And Sir Bill Connolly, who's a stand-up comedian, is Scottish. He suffered from Parkinson's disease dementia. So all of them have dementia. So the question, which type of dementia they falls into, is something that we have to address. So when we talk about dementia, we need to talk about this very famous picture. We've seen it at some stage of our medical career. It was founded by Dr. Alois Alzheimer, where one of his patients is Augusto Dieter in the early 19th centuries. Basically, this patient presented with behavioral symptoms and short-term memory loss. So upon her decease, so they've agreed that they're going to study her medical records, and the brain was brought to Munich. What they found was this degenerating neurons with bundles of fibrils and foci of severe staining deposits over the cortex. That's the whole start of the Alzheimer's disease. So basically what we know so far is because of the mutation, the APP molecule led to the beta amyloid being released, and then this caused the plaque being formed. Not only that, and we start to have all this neurofibrillary tangle, which is damaging to the brain cells in the long run. All right. So the features, the clinical features, are the one that we've mentioned earlier on about the 10 warning signs. Now, but when we start looking into the radiological perspective, in early dementia, you may not see that clear in CT brain. But later in the disease, as the disease progresses, you might see some cerebral atrophy. MRI, yes, is quite sensitive, but when we start looking at MRI, the focus will be on the hippocampal region as well. All right, so it's something that we can do in terms of investigation. The second most common type of dementia is worthwhile to be mentioned here is the vascular dementia. Yes, higher frequency in Asian countries. We need to go in and start treating the cardiovascular risk factors. But to formally diagnose, to formally diagnose somebody with dementia, vascular dementia, you need to have a temporal relationship between presence of dementia, a stroke or cerebrovascular disease, and there must be a correlation between the two of them. But Alzheimer's and vascular is just merely a tip of the iceberg. There are other types of dementia which is beyond the scope of these lectures. Okay. So we've talked about the cognitive aspect. We're going to move on to the non-cognitive. Okay. The non-cognitive is the most tricky one to treat in patients with dementia. It's the symptoms of disturbed perception, thought content, mood, or behavior frequently occurs in patients with dementia. Now, these are the ones that we always see in the clinic, and these are the most challenging one in terms of treating. Up to 90% of patients with dementia may have these symptoms, and it's the most is the one which is affecting the patients in terms of quality of life, and then also the caregiver as well. So screening should be done regularly. So in our settings, we use the NPI, Neuropsychiatric Inventory, which is a 12 neuropsychiatric domain, where we try to identify whether the patient have any of this BPSD. Talk about BPSD, we need to look into two aspects, which is the behavioral symptoms and psychological symptoms. So whenever we're in the clinical settings, we have to address to the patient and the carer whether the patient have any of them. And out of all these things, apathy, which is a lack of motivation, is the most prevalent of them all. Okay. Don't forget about depressions. Yes, we have tools as well. Pick a tool which is very simple, such as the geriatric depression scale, to address whether the patient might have any underlying dementia. Okay, so what can we do in a patient we suspect of dementia? Number one, get a very, very detailed history from the patient, family, and the carer. You need to do a full physical exams, because your patient might have vascular dementia. They might have a focal neurological signs. So you have to do a full general exams. Pick a cognitive assessment that you're familiarized with, that you're quite familiar with, as simple as MMSE would suffice. Okay, if you suspect of depression, do the screening. The basic investigation, just do some routine blood tests, but you need to include B12 and thyroid function tests and folate as well. VDRL is not recommended. And then you should do at least a neuroimaging, non-contrast head CT would suffice. Once you have established that, pick up the phone and call your neurologist, call your geriatricians, call your physician who have interest in terms of treating patients with dementia, and start making the referrals. Okay, so we're going to move on to this case discussion. This is a case I saw basically a couple of years back. A 69-year-old gentleman from Syria, and he had a stroke in 2004, full recovery, a bit of hypertension, a bit of dyslipidemia. But the key thing that he had complained, and the family complained, was this progressive frequent forgetfulness since 2017. Now, possibly it could have started even earlier, the moment he had a stroke, but there was a stepwise progression. Now, in terms of memory, the recent memory is affected, but the remote memory, meaning his past, the things that the memories that he had in the past is still intact. He also had a very stereotyped kind of repetitive behavior. And in terms of the BPSD, the one we mentioned earlier on, he has both the behavioral symptoms and the psychological symptoms, such as apathy and sundowning. The word sundowning basically means when the sun goes down, the symptoms get worse. Okay, but apart from that, he's doing quite well. So a bit about his background that we mentioned in geriatrics, we always try to focus a lot on the social aspect. Denied of any family history, non-smoker, just a bit of alcohol drinker. Education, Form 5, primary school teacher, retired police officer in 2002, Ketua Kampong since 2017. From here, we can see that he has affected his functional abilities to perform, you see, the dementia. Married, 3 children. And again, this dementia has affected his driving. That's why he stopped in 2016. Now, medication-wise, we're talking about your donepezil, memantine, aspirin, and statin. In terms of clinical examinations, like we said, he had full recovered and unremarkable. The baseline investigations are normal, but the CT brain performed shows multifocal all infarct with evidence of cerebral atrophy, particularly parietal temporal lobe. So what is the diagnosis? Basically, we're looking at two pathologies. We're looking at Alzheimer's with a possibility of a vascular dementia in the past. So this is what we term of the word, what we call by mixed dementia. The cognitive and the non-cognitive, as we mentioned earlier on. Okay, so this quite simple algorithm is from the second CPG, from the second edition CPG. I like this one because it looks better than the third, but the contents are still the same. So patient with dementia, you need to go in with pharmacological interventions. You need to start, on our part, we need to start diagnosing them and treat accordingly. Okay, if it's Alzheimer's disease, mild to moderate, there's a role for acetylcholinesterase, and there's a role for combination of therapy for both acetylcholinesterase and memantine. For vascular dementia, there is a role as well. All right, so for Lewy body dementia, we may consider rivastigmine. Then we also need to address the BPSD as well. So in terms of patient with dementia, we need to go in terms of the psychosocial intervention, need to get all this MDT team in, and then we need to promote the independence. So just very briefly about the drugs. So not many drugs in terms of dementia. Like we said, only 10% of the research being funded into the geriatrics for dementia. So what it targets is the acetylcholine deficits. It inhibits the acetylcholinesterase. Yes, we use it for mild to moderate. It shows significant improvements in terms of the cognition and global functioning, ADLs, and the neuropsychiatric. So patient, you can start with a simple dose of donepezil, 5 milligrams, and we escalate them up. So keep in mind about the side effects whenever you're reviewing patient in the clinic, about the GI disturbance, incontinence, falls, and insomnia. Those are the common side effects. In vascular dementia, yes, we also do initiate acetylcholinesterase as well. Memantine, an NMDA antagonist, very few side effects, quite clean drug. It works by inhibiting the NMDA receptor here because too much of activation will lead to excitotoxicity. We tend to use it to moderate to severe Alzheimer's disease, but in cases of mild cognitive impairment, there's not much role in it in terms of significance difference between memantine plus placebo. Okay, so sometimes we also use a combination therapy in both the memantine and the the donepezil as well. Yes, it shows some better outcome compared with placebos in terms of the cognitions, ADLS, global outcome, and behavior. So what happened to Mr. K? We saw him in the clinic. We saw him, he had a cut on his left cheek. Then we have to ask why. Seemingly there's frequent argument that led to physical aggression. One of the things that happened was Mr. K misidentified his wife close as his. Wife became upset, verbally aggressive. Both had a fight. Somehow he ended up physically aggressive, and then the doctor intervened, and the doctor ended up punching him. So this is where we call it as an emergent BPSD, where there's a severe distress, imminent danger, and disruptive and dangerous behavior. So this is a simple way of how to assess PTSD, developed by B.S. Skinner, a psychologist. You have to find out whether there's any triggering factors, all these things. What is the behavior that you're trying to address, and then what's the consequence, and then you need to consider whether this is an emergent or non-emergent BPSD. So for example, for Mr. K, this is what we call by emergent BPSD because there's a fight already. Okay, so what do we do in BPSD? we should always adopt the non-pharmacological way as a first-line strategy. Like we mentioned earlier on, identify and treat the underlying cause. If it's delirium, treat the cause. If it's a side effect of drugs, identify your drugs, and so on. Okay, there's a role for occupational therapists to do a cognitive stimulation therapy and training. Then we need to go in with the management using the psychological factors and environmental measures. Okay, so what are we talking about in terms of psychosocial intervention? It needs to involve the individual, family, and group. If they're stuck in 1950s, travel with them in time. Don't disagree with them. Your body language is so important. Okay, avoid finger pointing, scolding, threatening. Redirect them, reassure them. Okay, and then if you are the cause of the patient to be distressed, solution is easy, get out. Okay, so now moving on to the environmental measures. Okay, there are other things that we can adopt in terms of controlling the PTSD. For example, scheduled behavior modifications, low lighting levels, get them active with the activities, music, stimulation therapy, and pet therapy. So there are roles for all these other sort of environmental therapy as well. So now we have to talk about medications for PTSD as well. So there are roles for antipsychotic, cognitive enhancing, antidepressant, sedative, and analgesia. Analgesia treated according to the WHO analgesia ladder. So when we talk about antipsychotics, we have to mention about the 3 T's: target your behavior, start low, and time limit. Do not exceed more than 3 to 4 months. What I tend to use is risperidone, a bit of risperidone 0.5. Keep in mind about the FDA issue black box of the risk, increased risk of mortality, about 1 to 2%. So you need to time limit them as well. And keep in mind about the potential side effect. So rivastigmine, there is some modestly improved BPSD, particularly when you're dealing with Lewy body dementia. Antidepressants, yes, address if there's a depression, pick it up using your screening tools, and then you probably need to consider using SSRIs as well, but keep in mind of the side effects. Sedative, we try to avoid giving sedatives if we possibly can, but a short-acting, short half-life such as Ativan would be good enough. Okay. I'd like to mention about elderly abuse here as well. Yes, you need to pick it up in the clinic as well about any presence of elderly abuse. The rate is about 15.7% out there based on the studies. It's mainly more of a psychological, physical, and financial neglect as well. Okay, we mentioned about caregivers burden. So need to address the caregiver as well. You need to manage the patient with caregiver as well. Give them education, give them support, training courses, and then offer them respite care as well. Okay, and like Ramsey says, you need to start listening to your patient and you need to start listening to your carer. Finally, when we talk about dementia, we talk about palliative care. Advanced dementia is the terminal illness. You need to have a compassionate and shared decision making. Adopt an advanced care planning in early stage, okay? Because a patient who have an advanced care at an early stage, they're less likely to receive any aggressive intervention. Okay, comfort, focused care, food, hospital, antimicrobial therapy, and chronic daily medications. You need to address all those things as well. Okay, so just to wrap up, what happened? 15 minutes consultation end up more than 1 hour consultations. So educate the family, dementia and BPSD, importance of physical interaction. We got them involved in the carers group, dementia cause, avoid the triggering factor, a trial dose of risperidone. Just to summarize, keep in mind about the definition, screening, the 10 warning signs, the cognitive and BPSD, the types of dementia. Keep in mind about the pharmacological, non-pharmacological, carers burden, palliative care. Yes, if you suspect you have a patient with dementia, refer to the appropriate specialist. Okay, thank you.
Okay, thank you for Dr. Affizal's comprehensive review on this interesting topic. In view of time constraint, and we will let the audience to ask questions by using the chat box. And I think everybody is tired now and probably information overload. So we'll have a 5 minutes break, and then we will come back at 11:13 with the next lecture. Okay.